So, Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. Today's subspecialty lecture is about the lacrimal system. So, we'll start talking about the embryology and what is convenient to hear. So, hold on. So, be able to see the slides. Okay. So we'll not discuss the embryology in detail, so we'll just touch what is relevant to our clinical practice. As you know, lacrimal drainage system develops at earlier gestational age at the 7mm embryo than the secretory system, and this is because the secretory system hasn't to be embedded within the bony, developing the bony part as the excretory system. So the lacrimal glands continues to develop until even 3 to 4 years after birth. And as the developing excretory system embedded within the bony part, when you see a midline defect in the future like this gentleman, the lacrimal drainage system, interestingly, is patent. The ossification is completed at birth regarding the orbit, except the orbital apex. Why this piece of information is important? Because the bony surrounding the lacrimal apparatus are already ossified at birth, which means that we can utilize this bony landmark during the passage of the probe. Also, canalization starts at the lacrimal sac, then canaliculi, and lastly the nasolacrimal duct. And this is why you will find valves and ridges within the lacrimal apparatus due to segmental canalization. So you are able to see the prosthetic valve here, the valve of Waltz, the valve of Krauss, spiral valve of Hertel, Telfer, etc. The lower part of the lacrimal drainage system, which is a possession of the Hassener valve, is frequently persists in newborn. This is why lacrimal drainage system dysfunction is reported up to 20% of the newborn, but the true obstruction only 6%. Regarding the anatomy, the lacrimal gland is a modified sweat gland. It is merocrine, what we call it also ecrine gland, which is situated as the superior temporal orbit. And if you palpate it, this means that the lacrimal gland is enlarged. So normally you cannot palpate the orbital part of the lacrimal gland. It hasn't a true capsule. It is supported by the lacrimal fascia and retinal ligament. The palpebral loop can be visualized if you just invert the eyelid, or if you pull the eyelid like this and ask the patient to look on the extreme downward and inward. The accessory lacrimal glands. If we look at the conjunctiva, you will find at the border of the tarsus, we have the lacrimal gland of Warfarin, and at the fornix is glands of Krauss. So these are the accessory lacrimal glands. They have the same histopathological feature as the main lacrimal gland. This is a patient who underwent melorectomy. We just everted the eyelid, so this is a tarsal side, and this is the conjunctiva, palpebral conjunctiva here after we separate it. Usually we don't separate it directly above the tarsus to avoid damaging the glands of Warfarin. So we go just 2 millimeters and then inside the conjunctiva. This is a reflected bar, so this is almost at the fornix, at the superior fornix. You will be able to see some glands here. These are the glands of Krauss. If you take this part and send it to the histopathology, they are not able to tell you this is the accessory lacrimal gland or part from the main lacrimal gland unless you tell them from where you got it. So the accessory and the main lacrimal gland has the same characteristics. This is a Mueller muscle. If we look at the punctum is less than 0.5 millimeter and surrounded by dense fibroelastic ring, the prosthetic valve. This is why When you dilate the punctum, directly go with the probe. If you wait for a couple of seconds or a minute, you will find it again reclosed. And if the patient has punctal stenosis, when you want to evaluate the rest of the lacrimal drainage system, you're going to dilate in the clinic and you're going to irrigate. You have to tell the patient this is a diagnostic procedure. It is not a treatment. So what you're going to feel now is just to be sure that the lacrimal drainage system is patent, but this is not a treatment of your condition, because the punctum, after being dilated, it will come and close again, even if it is slightly opened. Usually we don't dilate that one if this is the only one which is functioning, because once you dilate it, sometimes it becomes completely obstructed. So the patient, after he went from your clinic, he will come back after your manipulation, the epiphora increased in this case. So better to do it when you decided for management, for further step on the same setting. The lower punctum locates 0.5 millimeter lateral to the lower or the upper one, and this is a very good landmark when you have cut wound here, if you want to assess the canalicular damage. If the lower punctum almost at the level of the upper punctum, slightly at the lateral border, the canalicular system mostly is intact because the medial canthal tendon is intact. But once this punctum is moved laterally, or the upper one is moved laterally, means that the canthal tendon here has been torn and the canalicular system just behind it. So the trauma which is efficient to cut the medial canthal tendon, mostly it cuts the canalicular system too. So the canalicular system is damaged. The canalicular system has 2 millimeter vertical part and 8 millimeters horizontal part. This is why when you dilate the punctum, don't dilate in this direction, because it is only 2 millimeters. If you dilate, mostly you are creating false passage. So just dilate the opening to get inlet. And once you are inside, rotate your Bowman probe or rotate your nettle chip dilator, punctal dilator in this direction, and then start to dilate. In 90% of patients, 85 to 90%, upper and lower canaliculi fuses together to form a common canalicus which opened on the lacrimal sac. But in 10 to 15%, each canaliculus opens separately within the lacrimal sac. So the patient has no common canaliculus. Presence of common canaliculus is crucial for successful pigtail intubation. So if you cannot get into the other canalicular system with the pigtail, don't insist. Otherwise, you may damage the whole canalicular system, because we know that 10 to 15% of the normal population, they don't have common canaliculus. The inlet here, it is not on the lateral aspect, in the posterior lateral aspect of the lacrimal sac. And probably if you are examining the nasal ostium post-DCR, you'll be able to appreciate the location which in the lateral wall of the lacrimal sac posteriorly. The lacrimal sac and nasolacrimal duct are structurally similar. So if you can get the whole lacrimal apparatus here and send it for a histopathological evaluation, they won't be able to tell you where is the end of the lacrimal sac and where is the end of the nasolacrimal duct. The landmark is the bonicae, the part that's surrounded with bone. This is the nasolacrimal duct. The part above is the lacrimal sac. The muscle which is attached to the lateral lacrimal sac wall, we call it horn of the vein muscle, and this is responsible for the pump mechanism. Lacrimal sac length is around 12 to 15 millimeter and 4 to 8 millimeter wide, while the nasolacrimal duct measures around 12 millimeters. This is in adults. So in pediatric age group, especially in younger age group, if you are doing probing in 1 year old or 1.5 year old, don't put this measurement as a standard, because they tend to be much smaller than this. And if you use this measurement, mostly you are advancing the probe to the mouth. The nasolacrimal duct opens at the inferior meatus, and it is not exactly in the axilla of the inferior turbinate attached to the lateral wall. It goes for just a couple of millimeters on the lateral wall and then opens. So when you examine with the endoscope, don't look at the axilla here exactly to see the opening. The opening is here. It's slightly downward around 4 to 5 millimeter from the axilla. When we go with the probe or we go with Q-tips, the metal on metal, how far should we go inside? In pediatric age group, just 1 inch, and in adults around 1.5 inch, 4 centimeter. So don't go far posteriorly to look for or to fish for the Bowman probe, which is inside the nasolacrimal duct. Regarding the bony lacrimal sac, if we look at the lacrimal sac fossa is formed by the frontal process of the maxilla and maxillary process of the frontal bone, and then almost at the middle or slightly posterior, we have suture line, then we have the lacrimal bone. So anterior lacrimal crest is located at the frontal process of maxilla, while posterior lacrimal crest locates at the lacrimal bone. The lacrimal bone is not opposite the nasal cavity directly. It is opposite the nasal cavity in only 7% entirely. But in 40%, you will find the anterior maxilla, anterior ethmoid is extended up to this area. Why this is important? Because when you are doing DCR, it is important to identify the nasal mucosa. So if you crack the bone and you find thin membrane, this is not the nasal mucosa. This is the ethmoidal sinus mucosa. Sometimes this is ballooned anterior ethmoidal cellule, what we call it Eger-Nazy. So you have to remove it and then remove the thin sheet of bone to reach to the nasal cavity and to be able to create anterior and posterior flaps. Regarding the nasolacrimal duct, the nasolacrimal duct length at the age of 2 weeks, it is only 10 millimeters, which increased up to 18 millimeters at almost 3 years. So we have elongation of the nasolacrimal duct, and the fastest period for elongation is the first 6 months. Also the width ranging from 2.2 millimeter to 4.2 between 2 weeks and 6 months. So it almost doubled the width in the first 6 months. And then slight enlargement up to 5.1 at almost 3 years duration. Why it's important to know this piece of information? Because sometimes the parents are complaining of watery eye of their kids. When you do dye appearance test, you see the fluorescence in the nose, which means that it is patent. But mostly they are delayed. So in this situation, it seems that it is a stenosis of the nasolacrimal duct. It is a wise decision to wait for the age of 3 years, so the nasolacrimal duct is expanding in length and width, hoping that this stenosis will improve with time. The only exception is the frequent discharge. If the child has frequent discharge, we cannot wait. We have to interfere. Otherwise, waiting is a wise decision. This is the anatomy of the nasal cavity, to be familiar. When you go the endoscope, directly this way you'll find middle turbinate and ancient process. But the inferior turbinate, you have to tip the endoscope to go parallel to the nasal floor. This is the ancient process, and this is the middle turbinate here. Middle turbinate, you cannot play with it. If you try to crack to make medialization, mostly you are inducing CSF leak. Unlike the inferior. Inferior, you can go with the FREER here, medialize or rotate this one. So you'll be able to see the opening here of the nasolacrimal duct just at the lateral wall. So it is safe to manipulate the inferior turbinate. It's too dangerous to manipulate the middle turbinate because the bony attachment at the cribriform plate and they can induce CSF leak. This is what we talked about regarding the nasal cavity opposite the lacrimal, the nasal cavity. The lacrimal bone opposite the nasal cavity. Regarding the lacrimal gland diseases, the lacrimal gland disease can induce dry eye, and the dry eye may be a blinding condition, inducing keratitis, and may end up with even endophthalmitis. We have inflammatory disease of the lacrimal gland, and the mass disease of the lacrimal gland can be fatal. As you know, carcinoma of the lacrimal gland, whatever the type, having poor prognosis. So clinical assessment of dry eye. The tear film function If you know the tear film function, you'll be able to appreciate symptoms and signs. So the function of the precorneal tear film is to smooth the optical surface of the cornea. So the patient, if it's not smooth, he will be having blaring of vision. It is a source of oxygen and supplies nutrient to the avascular cornea. So if we have defective here, we'll have corneal vascularization. It acts as a lubricant between the lids and the ocular surface. So any abnormality, the patient will have gritty sensation. It also responsible for removal of the foreign bodies and debris with the exfoliated cells through its draining. So if this one is not drained properly due to obstruction, patient will be having transient blur and dusty vision. It also has anti-infective properties. So if it is abnormal, patient will have redness and infection. We have long lists of dry eye, Sjogren, non-Sjogren, Sjogren primary or secondary, or keratoconjunctivitis sicca, which is non-Sjogren. Always remember that post-menopausal women or patients who have hormonal abnormalities, especially the childbearing period, or patient who is using contraceptive pills or hormonal intrauterine device, they tend to have dry eye. So don't forget to ask about these issues when you evaluate patients with dry eye, and ask them to avoid such hormonal therapy. The evaporative dry eye. The precorneal tear film may be reasonable in thickness due to the aqueous part is fine, but the problem either in the mucinous part or in the lipid part due to meibomian gland dysfunction or due to abnormalities in the lipid profile. So the patient will have early evaporation of the precorneal tear film. Also, reduced blink rate, like during reading or patient with Parkinson's, they tend to have also evaporative dry eye. Patients who are using Roaccutane, and Roaccutane or any retinoic acid derivatives like sunscreen, sunblock may induce dry eye. In specific, Roaccutane causes more and more inspissated secretions, which predispose to recurrent chalasia, and the secretion will not be normal. So patient will have a real evaporative dry eye, which may, by the way, stay for a longer duration than what we think. The extrinsic causes due to vitamin E deficiency, the topical medication, which is really a very common cause of dry eye. Patients who are using contact lens due to the lens, the preservative of the lens or the lens itself, or some ocular surface disease like allergy. The mucinous layer deficiency, trachoma was a very common cause, but also as a scarred cornea conjunctival disease like Steven Johnson or ocular cicatricial leukocyte induces dry eye. The break-up time test is not specific for any part of the precorneal tear film. It just give you the broad idea or generalized idea about the performance of the precorneal tear film. So it does not specify where is the fault. You cannot document with the break-up time that the patient has keratoconjunctivitis sicca, meibomian gland dysfunction, or problem with the mucinous layer. How to do break-up time test? The conjunctival cul-de-sac, the capacity of the conjunctival cul-de-sac is way less than the one drop. Okay. So when you put a drop of fluorescein inside, so actually you are distorting the whole precorneal tear film. You are increasing too much the aqueous part. So ideal break-up time with the fluorescein strip, just touch the upper part here of the conjunctiva. Make it wet and one touch. If you put more, so you will be having false measurement of the break-up time. Look at the tear meniscus, which is the part here of the precorneal tear film over the eyelid. Usually it is around 1 millimeter, which is half the width of the lid margin. You may have it very reduced like this patient, or you may have it excessively like patient with EPIPHORA or lacrimation. Schirmer test type 1 and type 2. Just think about this. If you want to assess the basic secretion, we need to put binoxynate, because topical anesthesia. We don't want the irritation induced by the paper itself when you put it inside the conjunctival cul-de-sac. So with anesthesia, you are testing the basic secretion. If you want to assess the performance of the main lacrimal gland, like patient with disease of the lacrimal glands, Sjogren syndrome, or autoimmune disease affecting the lacrimal gland, we have to irritate. Irritation can be induced by the Tumor test paper itself. So once you put it inside the conjunctival cul-de-sac, it is really irritant. So patient will have more and more production of tear. You can accentuate this one by trying to simulate other part of the nasopharynx by touching the mucosa of the nose. By the way, you can use 5 minutes or 2 minutes, and the results are similar. In phenol red thread test, this is have the advantage that no need to apply anesthesia very fast. So it's only 15 seconds, and it is pH sensitive. So when you put it inside and the pH is alkaline, it changes into a red color. Normally between 9 millimeter and 20 millimeters, and if it is less than 6 millimeters, considered as dry eye. Seldom we are using rose Bengal test to detect diseased epithelium. Mostly now we are using Laceration green, which is less irritant than the rose Bengal, and it applies also fluorescent with it. How to evaluate the meibomian gland? Meibomian glands can be evaluated by the meibography. As you can see it here, the arrangement of the meibomian gland. The lower eyelid has wider and shorter compared to the other, the upper eyelid. This is a meibomian gland dropout. To evaluate the lipid layer, we have quantitative measurement using tear film analyzer, which measures the thickness of the precorneal tear film lipid layer. Also, you can use the like specular reflection and use a mosaic appearance to see the effectiveness of the lipid layer of the precorneal tear film. So we have the aqueous layer evaluated by the Tumor test. We have the lipid layer evaluated by tear film analyzer, meibography, or specular reflection. But unfortunately, we haven't a way to evaluate the mucinous layer. But by exclusion, you can tell if the mucinous layer is affected or if you have scarred conjunctiva. The lacrimal gland enlargement, mostly it is inflammatory due to dacryocystitis, part of the idiopathic orbital inflammatory syndrome or IgG4 disease-related orbitopathy, can be sarcoidosis or other causes. Viral dacryocystitis is a common cause, sometimes associated with mumps, so you find the parotid gland also is enlarging. But always remember the neoplastic, and the neoplastic lesions are mostly epithelial. We have non-epithelial lymphoma can affect the lacrimal gland. And when we are talking about epithelial type, is one of the rare these part in the body that the malignancy is almost as equal as a benign lesion of the lacrimal gland. And prognosis of the lacrimal gland and malignancy is really poor. I think the lecture is beyond the lacrimal gland. You will be having it in the orbital disease in details. Now we'll go for evaluation of the lacrimal drain system. How do we evaluate the lacrimal drain system? Just look at the beauty of creature. So the lacrimal gland located at the highest point here, the superior temporal, and the lacrimal draining part at the lowest point here. When you evaluate the performance of the lacrimal excretion from the eye, you have to look at the whole area here. So the lateral consensus is higher than the medial consensus, and this is logic by 2 millimeters. So when you are blinking, the precorneal tear film will be squeezed, and according to the gravity, sloping down into the medial aspect. The lateral commissure here opposite the globe, so it is stuck to the globe. No space between the lateral commissure and the globe. So when you are closing, it squeezes the precorneal film. While the medial aspect here, we have a space, the lacus lacrimalis, and this is the value of having carunculum. So the punctum should be opposite the lacus lacrimalis, the tear leg here. If we have conjunctival callosis, redundancy of the conjunctiva, holding of the conjunctiva over the puncti, this area is scarred and there is no space between the globe and the puncti here. So the patient will be having watery eye. Also, lid margin is very important because it holds the tear meniscus here. So if we have any abnormalities here, the tear meniscus will be abnormal and the spreading of the tear film will be abnormal also. The puncti, when you are evaluating patient with watery eye, look at the puncti on the slit lamp and be careful about the position while the patient is closing the eyelid. It is not going markedly inward, is not everted outward, because it has to come just this way. If this is the corneal side, so when you are closing the eyelid, it goes this way. So the puncti will be opposite the lacus lacrimalis to be able to exclude the tear from the lacus lacrimalis. Of course, the tone and power of the orbicularis muscle is important during closure for bump mechanism and for good coaptation of the eyelid for better predisposing or ideal predisposing spreading of the precorneal tear film. And of course, valvular mechanism of the Rosenmuller and the Hasselbeck in particular. When we are talking about epiphora actually is a scientific term, meaning that the outflow is affected. So patient will not come to you and complains of epiphora, is complaining of watery eye. And your role here is to identify, is it lacrimation, overproduction, or a real epiphora due to defective drainage? So we have the anatomical epiphora and functional epiphora. The anatomical, maybe the punctum itself is affected, punctal phimosis, the canalicular system is affected either by stenosis or complete obstruction, or the lacrimal sac, we have lacrimal or tumor within the lacrimal sac. The nasolacrimal duct, which is by far the most common, either congenital or acquired, and the most common acquired is the primary acquired nasolacrimal duct obstruction. The functional failure, on the other hand, is related to the poor pump mechanism, which can be due to the punctum itself is displaced, the eyelid is lax, the orbicularis is weak, and of course, the most obvious one is the facial pulse. How to identify the site of the blockage? The dye disappearance test it does not add too much actually to our identification of the site of the obstruction. The dye disappearance test tells you that the dye is not excreted in the proper time from the eye. But is it due to washing out of the dye? Is it due to defective draining? Is it due to bump failure? Is it due to dry eye? So is the dye stays for longer duration? So dye disappearance test per se does not tell you anything unless you completed the exam. When you are doing dye disappearance test in pediatric age group, you put the fluorescein in both eyes, wait for 5 minutes and see the disappearance of dye. If it disappears, means that the lacrimal drainage system is fine, provided that the patient is not crying, the dye wasn't washed out and going out the eye because of the crying or small amount that the nurse has put inside or unequal amount. So we have some fallacies regarding the dye disappearance test. But the most accurate is the dye appearance test, or what we call it Jones primary. When you put fluorescein inside, just wait for 5 minutes and try to see it in the nose. Once you see it in the nose, 100%, this is the site here is open. Actually, we have only one exception. If this one is patent, this side is patent, and the fluorescein goes backward, and then the child sneezes, so the fluorescein in the nasopharynx came back through the nostril. This is very unlikely, but just for your knowledge, it may happen. How to retrieve the dye? The best is to use the nasopharyngeal swab. Nasopharyngeal swab is thin and malleable, so it does not irritate the child too much because the Q-tips is too big to go under the inferior turbinate or at the floor of the nasal cavity. So this one is better. If the fluorescein, you cannot see it in the nose, you may ask the mother to put the child in a supine position and face down. So the dye will not go backward, it will come out. And you may wait in the waiting area for a couple of minutes because sometimes this is really delayed. So after 15 minutes or 10 minutes, the mother may come to you and tell you, okay, the dye, we saw it from the nose. The dye disappearance test, it is graded into 5 grades. And for clinical practice, usually we grade it as obstructed if it is same color, delayed, the tinge of fluorescent there, or cleared normal if the no fluorescent. But for scientific classification in terms of, if you want to write it down in a graded way for publications, is divided into 5 grades. Grade 0 normal, so you don't see the fluorescent side, very faint tinge of fluorescent here, if ever. Grade 1, just a small stain of fluorescent at the tear meniscus. This is why we grouped this 1, 0, and 1 as normal. When you go for grade 2, you will find the fluorescent is diluted inside the conjunctival cul-de-sac, but some fluorescent in front of the cornea, and the color is going to the yellow color. It's not orange color, and hardly to see it in the real color. This is grade 3, 2. Grade 3, the fluorescent is diluted, but still the orange color is there. And grade 4, complete persistence of the dye. This is why also we group grade 5, grade 4, because the difference between them is really tricky, as a obstructed, and this one as a delayed, as you can see it here. Important issue here, when you go to retrieve the dye, don't go this way. Okay, so don't go this way. You have to go parallel to the floor of the nose and slightly lateral with the tip, so you are aiming at the nasolacrimal duct opening. If you have a positive regard, so when you press at the lacrimal sac, you have regard of mucopurulent discharge coming in. Okay, look at the regard. If you see the regard from the upper and lower puncti, no further intervention. That's it. So no need to do anything else because the diagnosis here is clear: chronic dacryocystitis due to nasolacrimal duct obstruction, and as the regard is coming from the upper and lower puncti, means that both puncti and the canalicular system are beta. Sometimes when you press, you'll find the regard coming only from the upper because you can get the lower one with your Q-tips. So in this situation, you try to press in a way that you don't kink the lower canaliculus to see the regard from the lower one. And if you don't see, it makes sense to just to probe the lower one to be sure that is it patent or obstructed, because sometimes if it is obstructed, be ready with monocanalicular stent. If you have no regard, you don't see the regard, and patient is having EPIPHORA, you have to probe the lacrimal apparatus. Or if you irrigate it, you will find the irrigation is coming from the lower canalicular system, or you irrigate from the lower is coming from the upper canalicular system. So there is obstruction here, but where is the obstruction? We don't know. So you have to go with the probe and see if you have hard stop. This means that the obstruction at the nasolacrimal duct. If soft stop, the obstruction at the common canaliculus. Why it is important to differentiate between these two groups? Because if the obstruction here at the lower part, stagnation of the tear will predispose to infection, and patient may have chronic dacryocystitis, may activate with acute dacryocystitis, so there is a clear medical indication for surgery. But if the obstruction at the common canalicular tear is not going or getting access to the lacrimal, lacrimal sac and nasolacrimal duct, so infection is unlikely. It is not 100% unlikely because it depends upon the lower part here. If it is obstructed also, so no access of the nasal secretion nor tear to the lacrimal drainage system. In this situation, the treatment is optional. So if the patient is bothered with epiphora, you go for PCR. If the patient can cope with epiphora and he or she has risk factor for dryness, diabetes, elderly patient, postmenopausal, using antihypertensive, using CNS medications, so they are more liable to have dry eye. Give them the option that if they can cope with the treatment, with the epiphora, just keep them in peace. If not, you can operate them. Usually, I tell the patient in this situation the steps of the procedure, including the osteotomy and the scar. So if they are really bothered, they will go for surgery. If they are not bothered, I'm leaning towards not to operate them. Indirect question: if you see the mascara or cochlear deposits here, mean that the epiphora is not severe. Otherwise, it will wash out. Or you can ask the patient, are you attending weddings or party for 2 or 3 hours without any problem? If they have problems, she will tell you that, oh, I cannot because of the makeup washed out. In male, ask them about reading, because when we have epiphora, the tear meniscus here causing minus length. So they aggravate the hypermetropia that they have. So they would be having difficulty with reading. The primary and secondary Jones dye test, if you put the fluorescent and you can retrieve the fluorescent, this is patent. If you cannot, you have 2 possibilities, either complete obstruction or partial obstruction. Or the canalicular system, the dye can get in or cannot get in because of the stenosis of the canalicular system. If the dye can get in and with irrigation, you have the fluorescent in the Q-tips, this means that canalicular system are fine and the stenosis is only on the nasolacrimal duct. But if when you irrigated, you have the patent but no fluorescent, means that the main problem in the canalicular system rather than the lacrimal sac system. Actually, seldom we are using this test in a practical way. To determine the site of the obstruction, the dacryocystigraphy and variant of the dacryocystigraphy, macrodacryocystigraphy, the dynamic with the MRI. The aim here, we are injecting the dye. So when you inject the dye here, the site of the obstruction will be evident. And this is for academic use. And if you have query, lacrimal sac extension or traumatic, and you want to see where is the end of the dye and if it is associated with diverticulum, so you are injecting the dye. So the patient is exposed to external beam radiation. On the other hand, in scintigraphy or dacryocystigraphy, scintigraphy, whatever the name that you will see, we are putting radioactive isotope inside the conjunctival called the sac without any pressure. So you are leaving the lacrimal drainage system for the normal drainage pathway mechanism. And then you are recording the emitted radiation from the dye. So this is to evaluate the functional obstruction. If you put the dye here and the dye goes continuously by blinking to the nasolacrimal duct, this is normal. But if it stops at any stage or very faint, this means that the bump is affected. You can utilize the UPM to evaluate the lacrimal sac, as you can see it here. The common canaliculus here, the canalicular system here, the upper and lower canalicular system with the UPM. We'll talk about the common diseases in lacrimal drainage system briefly. So the congenital nasolacrimal duct obstruction, as we know that the may not be evident in the first few months because the lacrimal drainage system is obstructed, yet it hasn't been challenged with the complete normal production of the lacrimal gland, because the lacrimal gland starts to produce normal tear just a couple of weeks to 1 or 3 years after birth. So it is not essentially to have the congenital the symptoms at birth, but within the 6 months we still consider it as a congenital nasolacrimal duct obstruction. Interestingly, you will find the quiet eye despite having the shot. If the source of infection is the conjunctival sac or cornea, it will be reddish and injected. But if the source from elsewhere, like the reservoir of the lacrimal sac, so interestingly, the ocular surface is not injected. Dye disappearance test and dye appearance test or dye retrieval test is very crucial to diagnose the disease. Complication, the patient may have acute infection, and this is the exception that we don't wait for 12 months. If they have acute infection, you have to treat them at earlier age group. And if they develop acute Dacryocystitis, usually they have multiple sites of obstruction, and stenting is important even in younger age group. The classical teaching, massage up to 1 year, then probing 1 to 2 years, and if fails, probing the stent. But this is not the issue nowadays. The massaging for the first 12 months, we still do agree with this, but be sure that they are doing the proper massaging, because most of the lacrimal drainage system, it opens in the first 6 months. Few numbers are opening from 6 to 12 months, but the advantage here is that if you do intervention at the age of 1 year, the success rate is similar to at the age of 6 months. So why should we expose the patient if there is even minimal chance to improve without intervention? Regarding probing, what we are telling the patient, we're gonna explore the lacrimal drainage system. If probing is enough, the simple type, we will not do any further manipulation. But if we have a complex obstruction, we have to go for stenting. So putting a stent or intubation is intraoperative decision, no matter what is the age of patient. We see a patient who are 4 or 5 years with only simple obstruction, and on the other hand, only 1 year, and they have multiple sites of obstruction, sometimes lacrimal sac atony, which instead putting the stent and even DCR later. The balloon dacryloplasty, it's expensive. And to do it, we have specific indications. We do prefer balloon dacryloplasty in patients with Down syndrome. Some authors, they prefer to do it in between probing and intubation. So they are doing the probing, the balloon dacryloplasty, and finally intubation. But in our experience, we found this is really advantageous in patients with Down syndrome. Regarding restenting, if the patient has failure probing, it makes sense to put a stent. But if he or she has failed intubation, it does not make any sense to operate the patient with the same technique. So what do you think that does it add? Unless you have clear, for example, early stent out within the first few days, but you put a stent and it is not functioning. So what do you think that when you put stent again, what it's going to do? So in this situation, I do prefer to go for DCR. And DCR is not scary in pediatric age group, which is as successful as adults, with some differences. As I told you, this is the history. Very important to ask about history of acute Dacryocystitis, because if the patient gave positive history, better to intubate as a first intervention. Also, previous treatment modalities. If the patient is coming to you and she had failed the probing, if she has or he has medical report and the previous surgeon, he tells you the steps of the procedure in the report, well and fine. But if you haven't, you don't know, he might have bony obstruction. So in this situation, if you haven't enough data about the previous surgery, usually I consent the patient for DCR, positive DCR, because it's not uncommon to find bony obstruction, and it does not make any sense to expose the patient to general anesthesia and then another surgery to take the consent from the parents. When you look at patient with EPIPHORA, always remember that a watery eye can be a manifestation of congenital glaucoma. So what I do recommend is to look at the cornea, and if the cornea are similar in size, well and good, but sometimes very early you may miss it. So just do dry retinoscope. If the scope is moving with, that he's hyperopic and he's not having a congenital glaucoma. But if he has myopia, this is a suspicious. Please have a look at the puncti, because if the patient has obstructed puncti, you have no excuse. You put the patient under general anesthesia, expose him to the whole hazards of anesthesia, and then will not be able to do anything. And if he has only one punctum is open, so be ready with monocanalicular stenting. Regarding taking cultural sensitivity, usually it is polymicrobial, so we don't do it routinely. Always remember to do dye disappearance test and dye appearance test. Regarding massage, the regular massage, which is originally described for congenital nasolacrimal duct obstruction, it is effective in adults in a big scale, but to do it in pediatric age group and age during infancy or even in neonates, it does not make any sense. The tip of the finger is too big for the area. And usually who is doing the massage is a mother, which has usually long nails, so it may damage this area. So the best way, and one more issue, you have to press downward. Just pressing downward for what? You can see here because the arrow here is making the pressure down. Do you think this is right? Because here we have the bony cage. So no matter what you are doing here, what you are pressing here, you are not transmitting the pressure to the lacrimal drainage system. There is a bone. So it does not make any sense to go to do this way and push downward. What I do recommend is just to use Q-tips and take the lower eyelid up, kinking the lacrimal apparatus, and do massage in this area, and that's it. So by this technique, you are actually increasing the pressure within the lacrimal sac, preventing the regurg of the secretions to the conjunctival cul-de-sac by kinking the canalicular system. So you are increasing the pressure within the lacrimal drainage system, the lacrimal sac, which will be transmitted already to the nasolacrimal. Going downward has nothing to do. We have bony cage here. If the obstruction does not resolve spontaneously within the first year, then you go with the probing. You dilate with the nettle shape dilator, then you go with the Bowman probe. You start with 1 because 0 can create false passage, and all manipulation through the upper one. See, when you go with the upper one and rotate this one up, you are going more anatomical. But if you go through the lower one and kink this one up, you are making so much stretch on the lower part here. So you may damage the canalicular system, the lower canalicular system. So all manipulation through the upper one, and start with the Bowman probe number 1, and then Bowman probe number 2, dilate the lower part. You may use Bowman probe number 3. Never ever use Bowman probe number 4, because number 4 is 1 millimeter, more than 1 millimeter. Number 1 is 0.8, 2.9, 3, 1 millimeter, and this one 1.1. So if you are exceeding 1, the maximum capacity of the canalicular system to dilate is 1 millimeter. So if you use more than 3, you may rupture the canalicular system and induce more and more fibrosis. When you go with metal on metal, always remember that you have to go perpendicular to the surface. Don't go this way. So you have to go perpendicular to the table and 15 degrees sideways. So you are hitting exactly the opening. Don't go so far. This is adults, so this is why you go so far, but still, here just to show you, usually we don't go that far. Only 4 centimeters in adults and 1 inch in pediatric age group. Look at the area between the medial canthi and the bridge of the nose, because if the bridge of the nose is wide, mostly you have to go and tilt your probe slightly medially up. And always remember the variance of the nasolacrimal duct obstruction, because if you have this diagram in your mind, it is a blind procedure which depends on your tactile sensation at the tip of your finger while you are advancing the probe. So by this one, you'll be able to appreciate which type of obstruction you are facing. Stent removal. Once the stent is slightly even, not completely out, you have to remove it. It is unlike adults that we can remove it from the nose or retrieve it from the bottom back. How to remove it? Usually hold the stent like this, try to pull it. The knot has to come out through the upper canalicular system, because we are manipulating through the upper, so the upper is dilatable more than the lower. Keep pulling till you have the knot out. You should have the knot out, okay? As you can see it here. Once the knot is out, then you can cut distal to the knot, between the knot and the punctum. So the knot is still in your hand, and then pull the lacrimal system. Don't remove the stent of others. Because if you don't know the technique, some people, they are putting black suture here, some people, they are fixing it to the nasal mucosa. So if you try to pull it, you'll have bleeding from the nose, or sometimes the black suture and the knot is too big, will not come out through the canalicular system, and it works as a dacryocystitis, which will induce chronic dacryocystitis. Removal of the stent from the nose is much easier, but it needs anesthesia in the pediatric age group. Just pull it from the under the turbinate. It's not from the middle meatus, it's from the inferior meatus after you cut it from above, and just simply pull it from the down here, as you can see. EPIPHORA in adults, you have to exclude causes of lacrimation first. Female is more likely to be affected than male, way common in female. Tumors are rare causes, and a disturbed vision during reading is a direct question to identify how much the EPIPHORA bothered the patient. To identify the site of obstruction is very important because, as I told you, it dramatically affects the success rate as well as the indication of treatment. Ophthalmic medications are the most common cause of iatrogenic punctal and canalicular scarring. And don't forget also viral conjunctivitis is a common cause of punctal obstruction. Radiotherapy of the medial cancer area and systemic chemotherapy with 5-FU is also an important cause of punctum and canalicular obstruction. If the patient is having thyroid disease, the use of radioactive iodine, especially in carcinoma, is associated with almost 4% incidence of CNLD obstruction. Acute and the chronic dacryocystitis. The acute dacryocystitis, as you can see, the inflammation here is below mostly the medial cancer tendon. If you have, you'll find only minimal extension above, but most of the inflammation below. And if you have fluctuation, pus anywhere has to be drained. If you open it by your own, dramatic relief of the symptoms, a faster improvement, and is way better than it bursts by its own. If it ruptures by its own, most of the fistula will happen. But if you do it bland with blade number 11, so fistula is unlikely, but you have to book the patient for DCR within 2 weeks. Chronic canaliculitis, any indolent conjunctivitis, which is not responding to treatment, or we think about canaliculitis. It's caused by Actinomyces israeli, and recently we have multiple organisms, but more recently they even found the Actinomyces israeli in electron microscopy, as Dr. Jafid Ali mentioned in his article. Symptoms of EPIPHORA, chronic mucobranch conjunctivitis, is not responding to conventional treatment. If you look at the punctum, you find very canalicular inflammation, bouting of the punctum. And you'll find concretion, which is the sulfur granules. But interestingly, when you do irrigation, despite having positive regard of scanty material, you will be having patent lacrimal drain system. So no NLD obstruction. And the mainstay of treatment is curettage. You have to do canaliculotomy, and then you may apply oxygen because it is anaerobes, and the follow-up with the penicillin is most effective. But you can Quinolone group is also effective in patients with canaliculitis, but the mainstay is to remove the sulfur granule. This is the scanty milky secretion coming from the puncti, and this is the sulfur granule coming out. Tumors of the lacrimal sac, fortunately, it is rare, and commonly they are invasion from the surrounding structure. Mostly they are epithelial, either carcinomas, papillomas, and it is more common in male, unlike the obstruction, which is more common in female. And the most common non-epithelial is lymphoma, which is more common in female. Regarding canalicular laceration, you will see it in the AR frequently. It may be simple or associated with other lead tube lacerations. How to identify the cut end? As I told you, look at the puncti. If it is distorted laterally, the medial cancer tendon is involved, and the wound extends to the conjunctiva, the canalicular system is involved, and you can use monocanalicular stent. Just will have this video. This is canalicular laceration. Start with dilatation, Once you identify the medial cut end, put the tissue in the normal position. Once you open the wound, you will see the medial cut end opposite the lateral one. So you can identify here, this is epithelium, blessing epithelium. Then you put the monocanalicular stent and try to suture. The minimum suture that you will be able to take is better because more suture inducing more fibrosis. Then you can use the Pigtail intubation. Dilate, irrigate from the other side. As you can see here, you can aspirate the fluorescent and then dilate both the monocanalicular stent. Usually we measure 10 millimeters to be inside. We cut it and then put it inside. As you can see it here, once you gauge in the right position, it will go smoothly and easily inside, and then close your wound. Regarding the use of Pigtail, just a short video. Be sure before using Pigtail that the rest of the canalicular system is patent through dilatation of the upper and lower, and then do irrigation. Very important to irrigate upper and lower to be sure that the lacrimal system is patent. Then use the Pigtail. I like the wide curvature, this one, and the blunt. Don't use the sharp one. Sharp one is really too dangerous. Just go in. Once you reach the lacrimal sac, you bypass the medial consult tendon, then go slightly out and rotate. Don't do any vigorous manipulation. Don't try too much because, as I told you, 15% is not having common calculus. But then thread the 6O proline in the hole here, then retrieve it. And after that, you can use stent. Stent comes in two sizes. The DCR stent, which is larger size, almost double the size of the pediatric Crawford. The bigger the stent, the easier the burying the knot inside, but difficult to pass the stent inside. So smaller stent, easier stent insertion, but difficult engaging the knot inside, and larger stent, difficult engagement, but easier entrance. This is the small one. You can see we put the proline inside, and once you get it, try to put the stent inside, guided by your proline, as you can see it here. And then let the assistant just pull this one, make it straight. So once they make straight, you'll find it coming from here. She's straightening now. You see? Okay. Then the trick here, you have to tie this one. If it is longer, you can take just a small snip here, cut this one, and then re-enter the proline again, as you can see it here, because this seems longer. So we cut this part. Be careful, don't touch this proline now, okay? Because if it comes out, everything will be repeated. Then just gently push it inside, you can see. Okay, so it will come here, then pull it, and then tie this one, tie 4, 5, 6 threads after the tying completely, as you can see, then cut. And this is a tricky part here. You pull the stent, hold only the suture. So you are forcing the stent to come on the other side and try to milk it, squeeze it. So the knot will be inside the tube. It will not stick out and irritate the patient or canalicular system. As you can see it here, this is very crucial step. Once the whole knot inside and the thread, as you can see now, then rotate the canalicular, the intubation, the tube inside. So the junction area will be inside, not opposite the eye, as you can see it. And that's the procedure, the Pigtail intubation. Okay, thank you for listening. If you have any question.